Good evening, everybody. This is Dr. Rick Lehman in St. Louis, Missouri. And tonight, in your corner with CORA, we're going to talk about ACL injuries. And of course, ACL injuries are extremely common in most practices, very common in sports practices. Last year, there were 400,000 ACL reconstructions done, and it's probably one of the most common injuries that we see. Females are substantially at higher risk with a ratio of approximately 5-to-1. And female soccer players, basketball players, volleyball players, male football players, basketball players, it's almost an epidemic. So we're going to jump right in, and I want everybody to introduce themselves. Dr. Evans, please introduce yourself.
Hey, I'm Nate Evans. I'm an orthopedic surgeon in Myrtle Beach, South Carolina. I work for OrthoSC, a private group of orthopedic surgeons.
And Amanda?
Hi, my name is Amanda Milanak. I'm a physical therapist with CORA Physical Therapy in the Myrtle Beach, South Carolina area.
Wow, that's awesome. So just to jump right in, Dr. Evans, let's start talking about the anatomy of the anterior cruciate ligament. And kind of what I'd like you to do is talk about the ACL anatomy and a little bit about the ALL anatomy, the anterior lateral ligament that's had much media over the last 2-3 years. And I think we should discuss the anatomy of both so we can understand what we're going to be talking about.
Sure. So the ligaments connect bone to bone, and in the middle of the knee, there's two cruciate ligaments, and cruciate just means to cross. So the ACL and the PCL cross over in front of each other and provide translational stability, so from front to back, and then also some rotational stability. And then the ALL, the anterior lateral ligament, like you said, is something that's gained attention in the last 4 or 5 years, but it's been described for 150 years or so. And it's either a distinct ligament or it's a thickening of the capsule or kind of a combination of the two. And there's different laboratory and histological kind of studies and things like that that have shown some of both, but it's an important stabilizer for some of the rotation of the knee.
Excellent. So in terms of the anterior lateral ligament, it has gained some popularity in the media of recent, and some people believe in it, some people believe in it less. But either way, I do think it has a role in anterior lateral stability, pivot shift, etc. So if we're going to talk about injury to the knee, ALL injury, ACL injury, what are the common mechanisms of anterior cruciate ligament or anterior cruciate combination ligament injuries?
So it can be kind of a higher energy trauma, so like a car accident, fall off of a ladder or something from a standing height, something like that. That's less common. What I see much more commonly is sports-related injuries. You already mentioned in the intro the different sports that are kind of more prone to it. And it is often a non-contact injury. So a lot of times you'll be watching sports and the guy will go down without getting hit, and people say, oh no, that's a bad one. And that's true. A lot of the times when I see patients, they're going to pivot. So whether it's getting away from a defender or move the ball from side to side, they're not getting struck. It can happen with a contact injury as well, but it's often a non-contact type of injury.
And kind of describe the pathology, i.e., what happens? Someone has a contact injury, a non-contact injury. Kind of describe how they present in the office, what their complaints would be, and what you would expect to see from a patient that's torn their ACL.
Sure. So usually the patient will describe a sensation or even hearing a pop in their knee. Usually it will feel very unstable right away. It's usually not an injury that people will continue playing with, although I've had kids that have played high school football playoff games with a torn ACL and then only later kind of said, hey, my knee still hurts. So it doesn't always present as very obvious, but most of the time it's a pop and then it's a large effusion, a large swelling inside the knee joint. And so most of the time that I see them in the office, it's a couple of days out from their injury. They get hurt on Friday night. We're seeing them Monday or Tuesday in the office, and at that point their knee's pretty swollen and pretty painful. So they limp because they can't straighten their knee all the way out from the swelling inside their knee, and they don't really want you messing with it. So a lot of the exam mechanisms that we'll talk about here, they're honestly not that good in the office if they're already big and swollen. On the field, right when it happens, great test. In the operating rooms, great test. Sometimes in the office, when we're evaluating the first time, it's hard to get a good exam on.
And Amanda, someone comes in, they've just torn their ACL, Dr. Evans sends them over. How are you going to treat that patient in terms of swelling reduction, extension, flexion, getting them ready for potential surgery or potential rehab?
Absolutely. So first thing, like y'all mentioned, we want to address their pain and swelling. So educating them on use of ice, elevation, rest, making sure that they're not aggravating the knee in any way, shape, or form. Let them have pain be their guide. A lot of times we'll even have these patients be in an assisted weight bearing position where they're using crutches, toe touch weight bearing, or even non-weight bearing at all. Want to reduce as much stress through that knee as possible. Then from there, we can go ahead and work some gentle range of motion to what they can tolerate. We want to make sure that we're maintaining all flexibility around ankle and hip, and then introducing some nice isometric quad contraction as well as hamstring contraction. If we can get some active movement of the knee into extension or flexion, that would be great. But if we can stick with isometric quad with knee extended, that would be perfect. And then we can go ahead and hit hip and gastroc there as well.
That's awesome. So Dr. Evans, explain that exam. And you're right, you know, patients come in, they're swollen, you try to pivot shift them, or you try to give them a Lachman test, and the exam's sometimes very difficult. I had a girl today who had 30 degrees of loss of full extension. Her exam was terrible. She was probably 30 to 70. So yeah, you're not going to get much of a physical exam. But go ahead and describe kind of the standard physical exam. Once swelling's resolved, then the patient is going to be a little bit more cooperative.
Yeah, so starting by just kind of looking at the knee and seeing if they're acute, if it's big and swollen. So if somebody comes in, they say, I had this horrible knee injury, and their knee looks pretty normal, they're 3 or 4 days out, my suspicion for an ACL tear is lower, not zero, but it's lower. But if a kid comes in and says, I planted my knee and they've got a big swollen knee, it's almost certainly an ACL tear. And there's other things that could be like a cartilage injury, like a patella dislocation, things like that. So I'll see, can they do a straight leg raise? Can they lift their heel up off the table? Does moving their patella around hurt? Are they tender focally anywhere? And then you start getting into the kind of the injury specific exams. So the Lachman's test, where you bend the knee to about 30 degrees or so flexion and try to anterior translate that tibia, try to shift it out of its normal position. And there's a grading system that we use for that, but essentially what you want to do is compare it to the other side, because some patients have pretty loose ligaments and other people have very tight knees. And so compare it to the other side and see if it's different. See if you feel a good solid endpoint, like the end of a rope getting caught, or how much does it move? How much does it translate? And then you can do the anterior drawer test. Maybe is not as reliable, but I still use it in my practice. And then if the patient will cooperate, you can use the pivot shift test, which really helps do the rotational stability. And in my hands, that seems to be a tougher one. It's really hard to get the patient to relax for that. It's one that I do in the operating room once they're asleep, but essentially you put the knee in extension, you put a valgus force on their knee, put an internal rotation force, and then start to bend the knee down. And if their ACL is out, you'll feel the knee kind of pop in. As their IT band goes from an extensor to a flexor, it'll shift and their knee will kind of sit back into place. Sometimes it's very dramatic, and rotationally you can just twist the knee all around. And that's, we might talk about later, some of the more severe injuries, but that's kind of how I go about it.
And explain the dial test. What's a dial test?
Yeah, a dial test is looking for kind of posterior lateral corner and sometimes PCL type of injuries to see, does this injury involve more than just the ACL? Is it kind of a more complex injury? And so you can put the patient either prone or supine, and then you want to compare how much their tibia externally rotates. And again, you compare it to the other side. And so if they externally rotate more, 30 degrees of flexion, you're concerned about a posterior lateral corner injury, so the lateral collateral ligament, some of the other associated ligaments there. If it's more at 90 degrees, you worry about the PCL being torn. And then if it's both, you can have both of those torn in addition to your ACL.
And I guess since we're talking about associated injuries, what are the associated injuries? I mean, yes, you could have a posterior lateral corner injury or a PCL injury, etc. But what are the more common associated injuries, or what are you looking for when you see that patient comes in, you examine them, they have a positive Lachman test? What other anatomical structures would you be concerned about?
So the main thing I'm going to worry about is the meniscus. So specifically lateral meniscus is a little bit more involved. So if they've got joint line tenderness, that's a concern. Certainly if they cannot extend their knee fully, or they have trouble bending and they describe feeling like there's something stopping them. So every once in a while we'll get like a bucket handle meniscus tear in, and those patients, it's different. A lot of the other patients don't like it if you move their knee, but they will let you do it. The bucket handle meniscus tears, if they're truly locked, they just can't. They almost want you to try to get it in full extension or flexion, and they're concerned that you can't. So certainly if a meniscus is a bucket handle tear, that could be more concerning. And then other associated injuries, this is not one that you can really find on a physical exam because the knee is going to be swollen anyway. But if you have like a cartilage injury, an osteochondral injury, that's something you're going to pick up more on the MRI. But that would be something else. If I see an ACL patient, that's one of the things I'm looking for.
And normally when you get that MRI, besides the torn ACL, what are the other associated lesions that you see in terms of bone marrow changes, or what other contusions, etc., do you see on an MRI?
So you look at the meniscus, specifically more the lateral meniscus, but it can be either side. It can be medial or lateral. And then you look at we'll call it like the kissing contusions, or the bony edema. So it's usually in the middle of the lateral femoral condyle and then the posterior aspect of the tibia. And that indicates that they had a pivot shift, that when their ACL gave out, their knee not only translated, but rotated, and then the end of the femur hit the tibia. And so for me, that's a really key thing, because usually you can tell that the ACL is torn on the MRI, but sometimes not. Sometimes it looks okay, but if they've got a pivot shift, if they've got bony contusions, then to me that ACL is not functioning. It was torn, and that's more concerning. And same thing if somebody comes in and says, hey, I tore my ACL, and maybe they're an older patient and you're not sure, is this a new injury? Their knee's not really swollen. It doesn't look very impressive. You get the MRI and their ACL's out, but they have no bony contusions, no joint effusion, things like that. Then that's something you can say, okay, this is an older injury. This is not necessarily, and that would change management in terms of if they've done well for years with the old ACL injury, that's not one that I'm looking to put on the surgery schedule in a couple of weeks.
No, that's excellent. I completely agree. I mean, some people are chronically ACL deficient. Like you said, they don't have any kissing lesions, no bone marrow edema. Meniscus is okay. You're going to generally try to treat those conservatively. Amanda, tell us about the KT1000 test. Kind of explain it, and what it's used for, and kind of what it does.
So the KT1000 is it's a device that we can put on the knee that's attached to a platform. And the way you set it up, it will actually measure the amount of translation that the tibia has on the femur. And then from there, that helps to determine how much laxity there is the knee. So it's a little more specific than just our hands-on Lachman or anterior drawer test.
That's excellent. And I think back in the day, we did a lot of KT1000 testing. We moved on to a little bit more of a digital dorsal kind of a mechanism, but certainly it gives us an objective number as to anterior translation. And we can also follow these people post-op and say, hey, look, they had X amount of millimeters. Now they have Y amount of millimeters. So they're obviously more stable. Amanda, go ahead and discuss conservative treatment for an anterior cruciate ligament injury. And I'm going to ask Dr. Evans in a minute who he treats conservatively and who he treats surgically. But I'd kind of like to know, if you send someone over and you guys are going to treat them conservatively, what does that mean? What does that entail?
So it definitely depends on where we're starting. If we're talking about that older individual that's had a ACL deficient knee for years and years and years, depending on where they're starting is going to help drive where we start as well. So if they come in and not really swollen, not a ton of knee pain, but reporting knee pain with walking stairs, squatting, a little bit of an instability with that, we can definitely start a little higher function there. If they're starting out more acute, then we definitely have to dial back to where we started with those pre-op patients, essentially, of pain control, elevation, ice, getting that swelling to come down. Taking the pressure out of the knee with reducing the swelling is going to allow their quad to function better. Getting their quad to function is going to give them more knee stability in the posterior plane, so not going to allow that tibia to translate as much posteriorly, so they'll get muscle stability. We also want to get their hamstring going to really give that ACL some more support to reduce the tibia from translating anteriorly. So we want to start calling on those muscles to give the knee the added stability that it may be lacking from those deficient ligaments in their knee. So once we get their range going, get their strength going from wherever they're starting, then we can add in more proprioceptive type exercises where we're working balance, more functional movements, getting them to maintain proper alignment of their hip, their knee, reduce stress on their ACL and other ligaments in their knee too, so that they can maintain a healthy knee.
And when you look at that athlete or that patient, they come in and the first question they ask you is, when can I go back to playing? Let's say you're taking someone a little older, golf or tennis. What are you going to tell them?
Again, depends on where they're starting. You know, if they're going to golf, chances are they're probably going to be able to return a little sooner than tennis or something that's a little more dynamic where they've got cutting, moving, those type of things going on. So it really depends on where they're starting and how long it's going to take for them to regain that muscle strength, maintain that swelling reduction. My mantra always with any athlete that's returning to any type of sport is if they're not confident in their knee, they need to hold off. Any type of inhibition or where they're not going to go full bore at it, it puts them at a higher risk for not only re-injuring the knee, but having secondary injuries to ankle, hip, or a fall where they're going to end up with a wrist or shoulder injury too.
And Dr. Evans, who are you going to treat conservatively, or how do you make the decision as to who you're going to treat conservatively and who you're going to treat surgically? And is that a discussion with the patient? Let them make the decision. You make the decision. How do you guys come to that conclusion?
I think the vast majority of these patients that I see are athletes. They've torn it in competition. So by definition, they're active individuals, and most of them want to get back to that, especially most of the kids or most of the patients that I see are high school kids. And so that's a pretty easy decision. The patient, the family, everybody kind of wants to get back. So those are almost all surgical. There's some special populations, pediatric ACLs. Those are ones that you might try to treat conservatively until they get closer to skeletal maturity, but that's a pretty rare entity. Same with older patients. I don't have a lot of patients. I think the oldest one I fixed is maybe in the mid 50s. After that, it's much more common to have fractures and things than it is to tear a ligament. And so it's just not a common thing. But if I had a patient in their 40s, 50s that was not very active, this was maybe a car accident or a fall off of a ladder or something that was not athletic, then we could certainly consider trying non-operative conservative treatment, do all those things that Amanda just talked about. And some of those patients end up with pretty stable knees. If they're not doing much pivoting type of injuries, they can be fine. I mean, there's NFL players, linemen, that don't have an ACL because they don't do any sort of pivoting, and they do fine. And so I think it's almost, it's usually kind of defined by how they tore their ACL. It will almost kind of always paint a picture of which way they're going with treatment.
Excellent. And give us your go-to surgery. Your 18-year-old middle linebacker comes in, tore his ACL playing football, or your 17-year-old soccer player on the women's soccer team tore her ACL. What do you tell them? What's your go-to procedure, or do you have a go-to procedure, and how do you decide what you're going to do for them surgically?
Yeah, I feel like this answer is probably always evolving for me. And if you ask me 6 months from now, I might change my answer. So don't hold me to anything. So I think there's kind of some things that we were going to touch on. I think for young athletes, autograft is almost always better than allograft, and meaning using their own tissue. So using either their quadriceps tendon, their hamstrings tendon, their patellar tendon, using something from their own knee has a much lower re-tear risk than any sort of cadaver graft. And so I think that's probably the main takeaway. Now, whether you choose hamstring or patellar tendon or quadriceps, I think depends a lot on training, a lot on experience. I know for me, we did almost all patellar tendons in training. When I got out, I started to do more hamstring tendons, and now I use probably more quadriceps tendon than anything. So I think they each have some of their inherent pluses and minuses. I think if I've got a football player, a soccer player, I might lean more towards a patellar tendon with a bone block that has a little bit better fixation maybe. I might avoid that in a jumping athlete like a volleyball player or basketball player because it decreases some of their anterior knee pain. And like I said, I think the quadriceps tendon graft is gaining in popularity, and I've been really happy with it in terms of you can get a good quality graft. It's a larger graft than the patellar tendon. The fixation seems to be very good. The patients that I'm seeing 6 months, 9 months out, they still seem to be very stable. Their quadriceps gets weak no matter what we use, so they don't lose anything in their rehab. So I think my go-to graft, I guess, would probably be the quadriceps tendon at this point.
And discuss that same surgery in somebody, not the quadriceps versus the BTB, but discuss your approach in somebody with open physes.
Yeah, so there's different strategies. If they're really young, again, really rare, you can try non-operative treatment and brace them, and they can do pretty well. If you're going to operate, they're close to skeletal maturity, you can make that decision. I've had some patients that, a girl that's maybe 16 and her growth plates aren't closed, she's probably going to close pretty soon. So you talk about when they started menarche and when how far along they are in skeletal maturity. And so you might treat them just like an adult, even if their physis is open. If you're trying to avoid the physis altogether, there's different techniques you can use to pass those grafts using fluoroscopy to make sure you're outside the graft, or using soft tissue grafts to cross the physes. Those don't seem to have as much of a long-term physeal damage, growth plate damage, as one with a bone block might have.
And what's the role of allograft? I mean, is there a role in your older patients for allograft, or do you ever use allograft? And you're right, the re-tear rate in a young athlete's totally unacceptable. I think we've all gone away from allograft reconstructions in contact athletes, young athletes. What about in your 45-year-old skier who tears his or her ACL and wants to ski and has recurrent instability? Is there a role for an allograft, and do you augment the allograft when you do it?
Yeah, so I think exactly the type of scenario you described it. The literature is pretty clear that the re-tear rate's much higher for athletes, young athletes, but patients in their 30s and 40s, there's not really much of a difference in their re-tear rate. And so that surgery, I think, is a little bit easier to recover in an allograft. So yeah, if I've got somebody that is in their late 30s, early mid 40s, 50s, then I'm probably using an allograft tendon. It's less donor site morbidity. You don't worry about the re-tear rate. They seem to rehab, but maybe a little bit faster without some of the long-term complications that you see with the increased risk of rupture in a young athlete. So yeah, I do use allograft in those situations. And the other time, we're probably going to head this way in a little bit, but like revision kind of settings, if we've already taken a graft from their knee, then you're talking about the option of using a different type of graft from their knee, or using cadaver graft, using allograft, or sometimes combining the two. And so that would be another situation that I'd use allograft.
And Amanda, do you think the rehab's any different? We had actually a pretty good discussion on quadriceps as a ACL graft. Do you think that rehab, or explain the rehab in terms of bone tendon bone, quadrupled hamstring, and a quadriceps graft, and is there any difference in terms of the rehab and the downtime and the return to sport with the 3 different graft choices?
So we would follow any protocol that Dr. Evans would provide for us, or whichever orthopedic did their surgery, based off the graft that they did. During rehab, we find that sometimes the patient has more pain from the graft site moving forward, and that does limit some of our rehab and how quickly we're able to progress. And again, that kind of is based off of patient to patient, how they heal, what their healing rate is, and where that graft came from. Some patients with bone patellar bone graft site, they have a lot of anterior knee pain that was not there preoperatively, but now postoperatively, they complain about that anterior knee pain, difficulty with end range flexion, um, feeling of instability whenever they're kneeling on the front of their knee, and high levels of poor confidence in the front of their knee as well. Same thing with hamstrings. Sometimes those hamstring grafts, they just are flared, and we spend more time almost trying to get that hamstring graft area to heal and recover, and that takes away from some of their ACL rehab, if you will. But it all ends up coming together where they fall right back into their timeline and get through their protocol. I've seen good results from the quad tendon grafts as well, where, like Dr. Evans said, we end up with quad deficiency anyways. So taking it from the quad, I haven't seen too much lagging pain, if you will, from that graft site, and their quad tends to recover nicely from it.